Our next speaker, our final speaker, is Dr. Hugo Aparicio from the Department of Neurology, who is a translational cardiovascular epidemiologist. He is an investigator of the Framingham Heart Study and the Black Women's Health Study, and I know is interested in longitudinal trajectory of cardiovascular health and subsequent cognitive decline and dementia. So our final speaker will be Dr. Aparicio, who will speak with us about social drivers and cardiovascular outcomes. Thank you.
Thank you very much for the kind introduction, and thank you for really the honor of getting to speak to everybody here and getting to hear such amazing talks about that. It's a common theme. Social drivers of health are a part of almost everybody's research here at BMC, and so I'm really pleased to be able to give this talk because I had spoken with Drs. Lobb and Shanahan, a few months ago about they were hoping that I could give a talk not so much diving into the details about cardiovascular disparities or clinical trials or anything kind of laborious that might bore you, but more might be just talking about what are the solutions-oriented work and strategies going forward with a big topic like cardiovascular health and mortality. So I'm an assistant professor of, actually I was just promoted last night to associate professor, but thank you. But I'm really just your friendly neighborhood stroke neurologist. I work in the trauma bay. That's my clinical life, and I really love it. But then during the day, I get to do stroke research with the Framingham Heart Study, with the Black Women's Health Study, and a VA cohort that we run. And I'm also a faculty at the Boston University Center for Anti-Racist Research, where I've been helping lead an external grant program there. So my own personal background, I've always been very curious and interested in how place and structures affect outcomes, because I'm a new American and I immigrated from La Paz, Bolivia, and I was acutely aware that I immigrated to the United States when I was very young with my family because of opportunity, right? Opportunity for socioeconomic opportunities, for education, but I also learned throughout my life that there were also disparities in health that occur at a global level. And right here's the city that I was born at in La Paz, Bolivia. You can see the stadium here. It's the highest altitude stadium in the world, I think, and the competing soccer teams have a very hard time breathing enough oxygen here, so we win sometimes due to that. But it's a beautiful city, modern city. A lot going on, a lot of colleges and universities and huge population. And you also have Boston here, another amazing city with a ton of history and in all these world-class hospitals that we have here. But there was a stark difference. In La Paz, Bolivia, the life expectancy is 70, and the life expectancy in Boston, as we've seen, is around 80 or 82. It might max out at. And so I was always acutely aware that drivers of health could vary by a lot just by the place that you're born. And so I just thought that this was really pertinent because also our keynote speaker today mentioned disparities just here within our own city. And coincidentally, I have up some pictures of Boston that drive this home, but also further emphasize social determinants of health, social drivers of health. This is a slide that our dean at the BU School of Public Health likes to show, where he did an overlay of our MBTA transit system with life expectancy or death rates per 1,000. And just like with our speaker this morning, if you were to get off here at Back Bay in Arlington, you'd have a premature death rate of only 2.6 per 1,000. Whereas if you get off at the Silver Line bus in Dorchester at Dudley Square, it's more than double the premature death rate just by where your place of residence is within the city. And then even further, if you overlay that map with where the people of color live in Boston, you can see that the places that are actually not even served by the MBTA tend to disproportionately be neighborhoods that are filled with African American and Hispanic and Latino people. And so unless you are going to the airport, really your options as a Latino or African American are fairly few for taking a train anywhere you want to go. And all of this goes back to inextricable social drivers of health that have been historically placed on these people through policies and laws. I was interested to pick up on this that had been come up again about the House Ownership Loan Corporation that was established in the 1930s to determine people's eligibility for like refinancing their mortgage debt during the Great Depression. So what would happen was that they would evaluate properties and code them either as neighborhoods that are red or hazardous, or yellow kind of in between, or blue, and then even the best was in green areas. And this was entirely determined pretty much by the makeup of the people that lived in those areas. Meaning, if there were a preponderance of Black African American families, the neighborhoods would be coded red. And if there was a preponderance of white families, the neighborhoods would be coded green. And this would lead to, this was called redlining, and this would lead to whether you were, lending institutions would lend you money, whether you were denied access to capital investments. And so your whole neighborhood would be built up, and the services and the hospitals and the schools would all be outlined around this. And so this historical redlining is a cause of what's come down through history as what's been social drivers of health have been really embedded in the places that people live. And another way to look at this is tree equity. So the amount of trees that are living in different parts of Boston, again, overlays with all of the maps that I've been showing in terms of neighborhoods with people of color have less number of trees and less shaded area, whereas areas that have historically not been disadvantaged tend to have a lot of tree cover. And this has a lot to do with environmental equity, where with climate change and with the heating of our cities, this will disproportionately affect neighborhoods with people of color. And so, again, not really entirely by coincidence, but I took this from the Boston Public Health Commission defining what health equity is. And it's the idea that everyone has the opportunity to achieve their health potential. No one is disadvantaged from achieving the potential because of social position, class, socioeconomic status, language proficiency, health literacy, or socially assigned circumstances like race, gender identity, ethnicity, religious beliefs, sexuality, or geography. And we also use this definition in our glossary for cultural change at BMC. And I think it's a strong one because it's broad, but it's entirely focusing on these aspects of social position and circumstance that I think have been under-recognized in the past with regards to health equity. And I will just say before we dive into it more, whenever I'm talking about race, I'm talking exactly what Dr. Adams was talking about, which is it's not a biological construct, but it's a social construct. And it's one that we use to help us understand our population and what the details of our population and what's made up in it, and also what inclusivity we have in the populations that we study in our research, but certainly not as a biological construct. And so also important to understand this difference between inequality and inequity. And so I like this this figure, this drawing that uses Shel Silverstein's giving tree. And you see that for inequality, it may be a comparison of someone who has access to resources or opportunities compared to somebody who does not. And equality could be framed as equally distributing tools and resources and assistance. However, the opportunity still may not be there, as this little boy might have the same height ladder that's provided, but still can't access the apples. And then for equity and for health equity, it's about using custom tools and maybe community-driven approaches where you are applying different sets of resources or standards of care, perhaps, so that people have the same access to health as other groups. But overall, in a perfect world, you would see health justice, which would be that you fix the underlying systems, right? The tree itself, you would rectify it so that given what tools and resources you have, you always have the same opportunity for that health outcome. And the tree model works in many different ways. I also like the health tree model that helps us understand that there are these underlying systems in our culture that have disenfranchised people traditionally. And these factors and these narratives are what underlie racism and sexism and ageism and ableism. And these are the root causes really of health. And they go through these social determinants of built environment, education, violence, employment, housing, and the social environments. And they work through health behaviors and they work through the development of risk factors to then lead to health outcomes. And we work in this. We all tend to work in this one sliver of health outcomes or disease, and what we're doing more and more is recognizing the root causes of disease, as many of the researchers here have been highlighting. What I find interesting about this tree is that there's no brain diseases here, which I think is glaringly missing, because ultimately cognitive aging and dealing with things like stroke and dementia are huge factors that fall exactly along this pathway. So again, with definitions, the WHO defines the social drivers, social determinants of health as conditions in which people are born, grow, work, worship, live, worship, and age, and the wider set of forces and systems shaping the conditions of daily life. But I also liked a further explanation by Dr. Mujahid, who was on a panel recently at one of the American Health Association conferences, where she tried to emphasize that social determinants are non-genetic and non-biological factors that are multi-level, multi-dimensional, and may occur over the life course. And they are shaped by money and power, and they work to unfairly distribute resources and opportunities throughout society. And she added, these are inextricably tied to factors like sex and race because of the power structures that have existed for forever in our country. And so as a researcher, I'm finally tying it back to research, right? But as a researcher, I found it helpful to take that broad view about social drivers of health. And actually the NIH has provided some very helpful frameworks that help you when you're doing the planning stages of your research to think carefully about these topics. And so this one particularly is from the National Institute on Minority Health and Health Disparities. And it's a mix of the socio-ecological model, which I'll talk about just a little bit, but also an earlier NIA framework for health disparities that have been developed. But basically what it's describing is this cross-section of, here on the x-axis, is levels of influence of social drivers of health at the individual, interpersonal, community, and societal level. And that's developed from that socio-ecological model I was speaking of. And then on the y-axis, different domains of influence, from the healthcare system where we operate to the socio-cultural environment, the physical built environment, and behavioral. And then they have a line here for the biological domain of influence. And so how health outcomes stratified across these two levels of influence and domains of influence can help you understand that when we do research on just one very small area, like say limited English proficiency for our quality metrics for what we do in our hospital. If we just research limited English proficiency here without consideration of all these other levels, it can be falsely attributed to one aspect or another. If there are disparities in limited English proficiency that cause less control of blood pressure, falsely attributing it to nativity status, being born in another country, or culture, or even worse, biological reasons for why there might be disparities. So this helps you, for example, look that, well, there's also family and peer norms within cultures or within families that have limited English proficiency that might also be affecting your interaction with your environment and your healthcare system. Or far over here, there might be policies and laws, for example, immigrants not being able to have driver's licenses, and so they might not come to the hospital as readily or as easily and not want to call an ambulance, or healthcare access. And so this helps you understand what are the things that you're missing in terms of discussing disparities that you see in your data. And it helps you tackle really complex problems, such as racism. And so what I really like about this publication that came out last year is it shows a historical and multi-level framework for how we might think about how racism affects cardiovascular risk factors and cardiovascular outcomes. And it starts all the way from policies in the 1700s through modern day present effects of redlining, describes how they might link to different forms of racism and discrimination, and then dives into these social drivers of health all the way from the cultural, institutional, and interpersonal through environment and through behavioral and through biological stressors, in fact. And then all of that leading through that kind of tree that we talked about of risk factors and behaviors through to an increased burden of cardiovascular disease and worse cardiovascular outcomes. And so I give this talk sometimes to divisions of stroke or divisions of cardiology, and it really opens eyes that we need to have such a broader view. It's not just blood pressure that causes stroke. It's also it's such a wider array of factors that go into the disparities that we see. And so the American Heart Association has recognized this and has created a call to action to address and consider structural racism as a driver of these health disparities. And there are some few points that they like to emphasize. One is to improve conditions in workplaces. Two is to create policies to improve quality of housing and neighborhood environments, eliminate inequities in access to healthcare, understand and transform attitudes about race, and investigate these joint multiple domains of racism and intersectionality on health. And moving beyond disparities research, I like this quote by Dr. Benson from the NINDS. It's time to start admiring the problem and it's time to start doing something about it. And what I've learned through my work at the Center for Anti-Racist Research is about combining really a lot of methods that go beyond our work as researchers. First, having interdisciplinary teams across disciplines, not just within medicine and statistics, doing community engagement, public scholarship, and also focusing on policy change from the outset. I think this is a group that needs no reminder of the kind of team science that's needed to address these complex topics. But it also goes into including the community in your team and building trust and relationship building, respect and transparency, so that we can go from no community involvement and having the academic centers as the center of our research into having community participation, but even having them initiate and lead the type of research that's needed to really implement change within communities. And then public scholarship, the problem of our research findings kind of staying stuck in limbo and not being translated into meaningful effects in our communities. It's frequently cited estimate that the gap between research discovery and its implementation is about 17 years. And even then, only 1 in 5 evidence-based interventions makes it into clinical practice. And so that needs to change. It can't just stop where it gets published into a journal. So solutions-oriented scholarship, op-eds, media outreach, art, narrative, town halls, community convenings, all needs to be part of our strategy. And just a silly example of me getting out of my comfort zone, giving a talk on stroke awareness in the Latino community in Spanish was I hate to hear myself talk, especially in Spanish, but this was the just me getting out of my comfort zone to disseminate our research. And then finally, policy change to reverse policies or laws that create health inequity and create ones that promote health equity. And this can be at any level, institutional, city, state, and national. And so it's incumbent on us to think about involving policy experts and policy teams at the outset when we're planning our research, even if we don't know what the results of our research is going to be, just so that we know who are the stakeholders, who are the policy makers that we're going to target and give our policy briefs to our white papers. A couple of brief examples just to finish up, because I wanted to put this into a little bit of context. So this, in terms of cardiovascular disease, there was a cluster randomized trial published of blood pressure reduction in Black barbershops a few years ago. And they had an amazing 27-point decrease in blood pressure compared to 9.3 in controls. And normal blood pressure achieved a net 63% compared to 11% of controls. And so what's remarkable here is they really took that approach where they tried to make an impact by making it convenient to get care. They reduced costs of the blood pressure medications, and they used trusted community members from black barbershops, black barbers and pharmacists. Amazingly, 40% of the people in this trial didn't have a primary care doctor, and they were actually assigned to the clinical trial MD for a kind of authorization and sign off on these medications. And as a result of recent research like this, the NIH has come to understand that primary and primordial prevention is so key. And the NINDS has developed these campaigns to reinforce among the African American community, especially African American males, that they're the highest risk subgroup and that they need to know their numbers and they need to screen for them earlier and they need to manage them tightly with their care provider. And then speaking of blood pressure, here I'm very proud of our own Tina Yarrington, who's developed this blood pressure screening campaign among pregnant women pregnant people in our OBGYN care groups. And they've, especially during the COVID pandemic, they were without access to the normal prenatal screening. And so she developed a digital intervention at home where they could monitor their blood pressure. And this is, again, like recognizing the highest risk subgroups with that intersectionality of sex and race, and then implementing something that is going to give short-term benefits. But also there are long-term benefits. In the Black women's health study, we've understood that hypertensive disorders of pregnancy, such the ones that Tina is trying to screen for and prevent, increased long-term risk of stroke in U.S. Black women, almost doubling the risk in some situations for stroke longitudinally. And so it's really important for these life course approaches, early intervention, screening, and treatment for later outcomes. And then this, just very quickly, was example, Dr. South is doing these greening interventions in Philadelphia that have actually been shown to improve mental health and decrease heart rate variability or resting heart rate. And these modifications that can be done to our structural environment to help health outcomes. And finally, at the policy level, just illustrating that changes in laws that increase health access, like the Affordable Care Act, Obamacare, in the states that had this early Medicaid expansion, there was better modest improvements in management of cardiovascular risk factors among low-income individuals, greater likelihood of getting goal-directed medical therapy among Hispanic patients. But sometimes the laws aren't entirely enough. They did not see any improvements in a receipt of cardiac resynchronization therapy, and there was overall not a huge difference in hospitalization for heart failure due to early adoption of the ACA. So, just in summary, this is the kind of a way forward for us to envision how to do our research a little bit differently, how to consider social drivers of health for these really striking and difficult to tackle disparities in cardiovascular health. But I hope it's actually across all disciplines, it's helpful to think about these topics when we're planning and trying to solve these health inequities. So just thank you to people I do research with, and a little time for questions.
Yeah, time for one question, if there is one, for Dr. Aparicio.
Well, I wanted to make the question after, Doctor, but it's not exactly what you were talking, but it's like they said academic or scientific community usually measures successful stories or success events based on publications or how many dollars are funding. What is your advice? How do we measure these success interventions without using the usual metrics? Or how do you self-evaluate what needs to do better, or what we keep moving?
Mm-hmm. Well, I think that that's a difficult, for at least for cardiovascular disease and dementia, that's so difficult because of this problem that interventions that you implement now on social drivers of health, you won't see the effects of it. If you implement something in the early life course in childhood, let's say, you won't see the effects of it for another 50 years in terms of decreasing stroke events, or another perhaps 70 years when you're talking about decreasing dementia. So I think that there's other aspects to this that we need to be more satisfied with these intermediate metrics like blood pressure control, glucose control, these more short-term driver determinants that are moderate mediators for longer-term outcomes. I would say that there's been a recent push to create health equity quality metrics that could be, like platforms that show how your systems are working to decrease health disparities. And that could be something that could drive at least standardization of initiatives at the hospital level or at the systems level, but possibly could decrease inequities a little quicker by at least using common metrics and common language around what that means.